Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Hi, I'm Vince Kokich Jr., and this is my practice inspiration. I thought it would be fun to speak about orthodontic failures. I think it's something that isn't spoken about probably enough, but it's important for us to continue learning by the things that maybe don't go as well as we want, or maybe that we do wrong. It's entitled Orthodontic Failures, Oversight, Undertreatment, or Communication Breakdown. These are my team, Greg Kinzer on the right, Jim Janikiewski on the left. I feel very fortunate to have the opportunity to work with them because I've learned so much about periodontics, restorative dentistry, and hopefully I've taught them something about orthodontics. And so throughout what we talk about today, you'll see a lot of their influence in it as well. When you have a team, you have to have certain qualities that work well. And what I mean by that is when you see these words come up on the screen, they really apply to certain aspects of ourselves that make an interdisciplinary team work, such as having respect for each other, similar interests, having the same abilities that are comparable and also challenging each other, because it really is what's going to enable us to be able to produce aesthetic and functional dentistry and really have fun doing it. It also has to be done in a very seamless manner, because if we're working on a patient but not really working well together, our patients will know. And that's when we can start to see certain problems, where maybe we have a failure, whether it's an orthodontic or a restorative failure, nonetheless it's a failure. Now when you define failure, it really means something that falls short of what is expected or required. Maybe it's something that we anticipate seeing at the end, or something that we didn't, but it nonetheless is something that we really would like to avoid if at all possible. So I want to focus on orthodontic failures. Now when you look at this picture, this is a patient who had an implant placed too early. The patient continued to grow, and they just kept trying to rectify a bony defect that ultimately occurred. Now, hopefully none of you will experience a situation like this. Fortunately, this was not my patient, but I think it's a good example of maybe what a very severe orthodontic problem could be. What I want to do is focus on these three patients in particular, because they all have very different orthodontic problems, or what I consider an orthodontic problem. But I think they're very valuable as we learn about the different aspects of being able to treat patients. And I'm going to entitle those Oversight, Communication Breakdown, and Undertreatment. And so we'll talk about oversight and undertreatment first, and then we'll finish with the communication breakdown. So when I think about oversight, I really think that we can relate it to the patient who is missing a lateral incisor. Now, I was sent this radiograph by a colleague with the question of, what do I do? And this is the radiograph that was taken at the end of treatment. Obviously, the patient's missing the upper right lateral incisor, and everything looks really quite good. It's set up well for the implant to be placed when the patient's at age appropriate. But 3 years later, now when the patient is able to have the implant placed because he's done growing, there isn't enough room. And so when you look at the spacing periapically between the canine and the central incisor, there just isn't enough room to realistically place an implant. So what do you do? Well, this could potentially be a problem. So was this an oversight by the orthodontist in managing this patient's retention? Possibly, but when you ask yourself the question, how often does this happen? We have to refer back to the literature. Taylor Olson published this paper, and he was one of our grad students at the University of Washington. And what he wanted to find out was how often the central and the canine roots will converge back towards each other after orthodontic treatment is completed. And what he found out was that in 11% of patients, you will see this become a problem. Okay, well, you'll just have to decide, is 11% enough to warrant doing something different in your protocol? For me, it was, because what they also found is that when they used fixed retention, they never saw a problem. So what I want to show you is how I utilize fixed retention to prevent this as an orthodontic problem in my practice. It's pretty simple. Using a fixed retainer that's bonded to the canine and the central incisor on the palatal, I'm able to maintain a very aesthetic appearance because the pontic tooth appears like it's emerging out of the tissue. But the most important part of this type of retention is that it maintains the alignment of the central incisor and the canine long term. As long as it's staying bonded, you know that those teeth are going to remain parallel right where you finished the orthodontic treatment. So if a patient has to wait 10 years before they can have their implant placed, you should feel pretty good that you're also going to have the implants placed that you want. Now, these types of patients, just to show you an example, this is Haley, and when you look at the lateral incisors bilaterally, it looks like she has that tooth, but basically it's just a facing of a tooth that's held in between those teeth by a rigid wire that's curled over on the terminal ends. Very inexpensive, my lab makes these, and the patients love them because they feel like they have those teeth. They can eat with them, they talk with them, function, everything is normal. And in fact, when you see this photo, the 2-year follow-up, they actually look better the longer that they've been in there because the tissue starts to adapt to them and they even appear more like they're emerging out of the tissue. So fixed retention is really the only way that I go now with patients missing lateral incisors. I also have them wear an Essex retainer at night just to protect the retainer, and for some reason if it came loose, I don't want them to swallow it or aspirate it. Now, the second type of orthodontic failure could be undertreatment. Okay, when you think about undertreatment, that can have a lot of variations to it. Well, I want to show you Nate because Nate's an interesting story. Now, when Nate came into the practice, he wanted to have nicer looking teeth, as most of our patients do. But when you look at the crowding that he's experienced in the lower and upper anterior, you start to wonder, well, how am I going to align all those teeth? All right, well, here is the clinical challenge, probably the most important clinical challenge when you think about the different treatment alternatives. He has a real thin phenotype in the lower anterior. So if you're thinking about aligning those teeth, treating him non-extraction, you will inevitably expand laterally and anteriorly. So the question that comes up is, will the soft tissue be able to handle this as you're aligning those teeth? Okay? He's probably at a higher risk for recession because of his phenotype. Here's a view from the occlusal. You can see how much crowding he has. And the line that's drawn there actually indicates about where ideally those teeth should be positioned. Well, there's no way that you can keep those teeth in that position. So ideally, if you were to align the teeth, what's going to happen is they're going to move anteriorly. So the question is, if we want to go back to where they should be, what is going to be our option? And well, probably is going to involve taking out teeth. So for example, if you took out first premolars, you could retract the canines and basically unravel the lower incisor crowding laterally without having much change anteroposteriorly. Another possibility would be taking out a lower incisor. In doing that, you can resolve the crowding, move the other incisors into that space, and essentially keep the central incisors and the lateral incisors in an ideal position. Okay. Now, when you're taking out teeth in the lower, you have to match that in the upper as long as they are class 1. If they had a different malocclusion, it may work to just take out lower teeth. Okay. Well, this is what his head film looks like. This is what his profile looks like. So if we really break that down and start to look at some cephalometric numbers, you can see that his upper incisor relative to his skull and his maxilla are actually pretty darn good. When you look at where his mandible is and you look at the A and B angle, you can see that it's fairly exaggerated. However, his overall profile is still quite acceptable. Right? But if you think about this and really look at what we would think would be normal as far as cephalometric numbers, the ideal position for the mandible was probably somewhere around here, which is a fair bit different from where he is now. So that may play a part in how you treatment plan Nate. So what are our treatment options? Well, it comes down to about 4. Because of the crowding, you could take upper and lower premolars out since he's class 1. You could also take lower premolars out or an lower incisor and create excess overjet, do surgery to advance the mandible into a normal overbite and overjet relationship. You could do essentially the same thing with number 3, but all you're doing is not taking teeth out, but you're putting temporary anchorage devices in the posterior to be able to retract the whole arch. The goal would be in both numbers 2 and 3 to create overjet so that you could do orthognathic surgery to move the mandible forward. The 4th option would be doing non-extraction, proclining the lower incisors, and perhaps doing some interproximal reduction to be able to deal with the crowding. Well, when I look at those 4 options, the top 2 for me are number 2 and 3 because they involve jaw surgery. And I think that's going to give him a nicer profile. It's going to allow for the lower incisors crowding to be alleviated most easily. Problem is, just as it would be in your offices with certain patients, mom says, you're not going to take teeth out and you're not going to do jaw surgery because she had a poor experience with both extractions and with surgery. So now we don't really want to do number 1. 2 and 3 really we can't do because of parental guidance. And we're left with number 4. Now number 4 could possibly be an option that would work, but you have to help it by doing surgically assisted orthodontics, or what you may refer to as surgically facilitated orthodontic treatment. And so that's the road that we elected to go down with Nate. So as you see the photos, you can see from pre-surgery all the way through having the corticotomies placed. Basically, this process, you flap the area, you induce trauma, and by doing that, you're creating this increased cellular turnover so that the bone remodels more quickly and the teeth ultimately move faster. Now, that's not the reason that we're doing it to have faster treatment, but it is a nice byproduct of it. We're actually doing the corticotomies and the bone grafting, as you can see in the left picture, to support the tooth movement that we're doing. Okay. So here he is after the surgery is completed. We're now ready to start orthodontic treatment. And when you look at this panel of photos, you can see from 1 week all the way up through 4 months, and the lower anterior crowding has been aligned really quite nicely. Now, if you look at this when everything is said and done, and you look carefully at the inclination of the lower incisors, you can see how upright they are. Now, this only is achievable when you're treating him non-extraction if you have bone to support that tooth movement, because otherwise you'd be moving those teeth into a place where there is no bone. Okay. Posterior occlusion really was always pretty good. Now we just tidied things up and allowed for the anterior crowding to be resolved. The point of showing this picture when you look at his head film before and after, and I blow up this one, is you can see the new bone that is labial to the lower anterior teeth, thus supporting the tooth movement that we proposed. Okay, was this under treatment by the orthodontist because we didn't use jaw surgery? I think that's a question you could ask, but the question that really should be asked is, well, was the family happy? Were they ultimately pleased with the way that his treatment turned out? And they were. So you may be able to say this is a failure because it wasn't exactly the way that the ideal treatment plan could have been, but it certainly was a nice alternative, and the patient ended up doing just fine. So when you think about utilizing surgically assisted orthodontics, there are some benefits, certainly. One of those benefits is that you can develop arch forms without really increasing the periodontal risk because you're adding bone to support that tooth movement. You're also providing additional treatment options, which is a huge advantage for us as orthodontists. And as a third one, but again, not the reason we're doing it, you can increase speed. Okay. Number 3, and the final failure that potentially you may see, is communication breakdown. Now, when I think of that, I think that this patient, this Tyler, is an excellent patient to illustrate when communication goes awry. Tyler's a nice-looking, normal 11-year-old boy who comes in, and again, he's not a patient of mine, but it's a patient that I think we can learn a lot from. He comes in, he has some impacted canines. Everything else looks normal. Eruption pattern where he is for 11 years old is really quite good. And because he has impacted canines, the plan is to surgically expose those canines and allow the teeth to erupt, or physically erupt those teeth after gaining access to them. Right? Very normal plan as you would work an oral surgeon with an orthodontist or a periodontist and an orthodontist, whatever you want to follow. Now, when you look at this photo, after the teeth have been exposed, the attachment to those canines is not really very ideal. In fact, I think the attachment is more on the root of the tooth. That's probably why his right canine has already come off. So as things go along and they're reattached, and the patient has those teeth moved into position, you can see the occlusion looks like it's coming together reasonably well, but those teeth are still not coming down. And it's very difficult to try and get those teeth into position. Now, when you take another radiograph several months later, because the patient's having difficulty, or the orthodontist is having difficulty getting those teeth in, and you look at it more closely, you can see that the root of the upper left central incisor has been almost completely resorbed. And then there is also some blunting of both lateral incisors and the upper right central incisor. So this is a problem. Okay. At this point, you're also seeing changes to the whole occlusal plane because those canines are behaving like ankylosed teeth. So now, patient looks unlike he should look. Okay. Now, when the patient smiles, he shows no incisor display at rest and also no incisor display on smiling. And this is a real significant problem, especially since he's probably about 14 years old now, 15 maybe. And when you measure to find out where the incisal edges are under the lip, they're several millimeters under the lip. So the plan was initially to take the canines out, which have been done at this point, and they went back and forth with the team that was originally involved. They couldn't really agree, so a new team came on. Fortunately, it was a team that really had the idea of utilizing interdisciplinary dentistry. The plan was to close the spaces where those canines were extracted, retract the anterior teeth, and do two-jaw surgery to downfracture the maxilla, rotate it forward and down to expose the incisors so the patient has a nice-looking smile, and ultimately finish his long orthodontic treatment. So when everything is said and done and the spaces have been closed and he's ready for surgery, this is what he looks like. After surgery, you can see his occlusion now fits. The premolars, which were in the canine position, look fine. They look normal and the occlusion has been balanced on them. And now when he smiles and when his lip is at rest, you actually have normal incisor display. Okay. The roots of the teeth, tooth number 9, or the upper left central incisor, is still significantly resorbed, but it has remarkably little mobility. And so the plan at this point is just to monitor, keep it and see how well it does. If the tooth fails, it could be a single tooth implant. Okay? Very straightforward solution to that problem. But now, when you look at the before and after, he went from a devastating aesthetic problem to a much nicer final result. After the restorative is completed in the anterior, it looks like he has a beautiful smile again. Okay. This is 12-year follow-up, and if you had questions on how long that central incisor would do well, it's doing fine 12 years later. So the question that I would ask for this type of treatment, considering the failures that we're talking about, is, was this really a communication breakdown by the interdisciplinary team? I think it'd be hard to say it isn't. So I would say absolutely yes. Well, what is one way that we can potentially minimize the risk for this happening in the future? I think that's pretty obvious. Communication. Making sure that we talk among our teams, whoever they may be. It may just be an orthodontist and a restorative dentist. It could be as significant as all of the specialties working together to treat one patient. Communication is the key. And when I look at all three of these different possible failures, the one that probably is most important, and the one that you may see most in your practice, is the communication breakdown. And because of that, we really have to make sure that we think like our teammates. And if we can think like our teammates, we can really have successful treatments. Thank you very much.